Posteriolateral rotary instability of the elbow. The anatomy includes the humerus, the ulna, the radius, the radial collateral ligament, the annular ligament, and the lateral ligament complex, which includes the ulnar collateral ligament. What is posterior lateral instability? It is when the proximal head of the radius and or the proximal head of the ulna subluxates posterolaterally from the distal end of the humerus. There are three types, which include type 1, which only involves the lateral collateral ligament complex. Type 2 includes the lateral ligament complex along with anterior and posterior tissue damage. Finally, type 3 includes lateral ligament complex, posterior and anterior tissue damage, and damage to the medial collateral ligament. This is all damaged while the annular ligament stays intact no matter the type. Pathology is and can only be direct trauma. Trauma almost always involves subluxation or dislocation. Mechanism of injury is falling on an outstretched hand. It has to be in a valgus stress with the arm in supination with an axial load along with it. Signs and symptoms include lateral elbow pain, clicking, locking, or snapping when moving the elbow, activities that put the elbow into extension. Activities such as pushing up out of a chair like the picture shown. A differential diagnosis includes ulnar collateral ligament tear, which you would use in a valgus stress test to rule out, and a normal subluxation that causes no instability. There are three special tests: the lateral pivot shift test, posterior lateral rotary drawer test, and the stand-up test.
To talk about the lateral pivot shift test or apprehension test for posterolateral rotatory instability of the elbow. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to Physio Tutors. Posterolateral rotatory instability, abbreviated as PLRI, is the most commonly encountered pattern of elbow instability. PLRI typically occurs as a result of a fall on the outstretched arm, generating an axial load, valgus force, and an external rotation movement about the forearm with respect to the humerus. This causes the radial head and proximal ulna to subluxate posterolaterally away from the humerus in a rotatory fashion, detaching or tearing the lateral collateral ligament complex in stage 1. In a more severe stage 2, the tissue disruption progresses anteriorly and posteriorly around the elbow to the medial side, and in stage 3, the injury involves the medial collateral ligament or even the common flexor pronator origin as well. Regan et al. In the year 2006 have found a sensitivity of 100% for the anesthetized patient with the lateral pivot shift test with an unknown specificity, and a sensitivity of 37.5 for the awake patient in the apprehension test with an unknown specificity as well. For this reason, we give this test a questionable clinical value in practice. The execution of the lateral pivot shift test in the elbow is similar to the performance of the lateral pivot shift test in the knee. To perform the test, have your patient in supine lying position with the arm overhead and the examiner standing at the head of the table. Start with the elbow in full extension and gently bring the forearm into supination by rotating the patient's wrist. While slowly flexing the elbow, the supination torque is progressively increased, while a valgus torque at the elbow and an axial load along the forearm are added. Maximum subluxation usually occurs around 40 degrees of flexion, at which time the supination is reduced and only a pure valgus torque is maintained. This test is positive if a subluxation of the radial head is witnessed by a prominent bump on the posterolateral elbow and dimpling of the skin behind the radial head that occurs as the posterolateral capsule is pulled into the joint. With further flexion, the elbow reduces with a visible and palpable clunk. It is important to relax the supination torque for reduction to occur without damaging the elbow. As this test is usually impossible to perform in the awake patient, the test is rather positive if your patient experiences apprehension during the movement. The patient may verbalize that the joint felt as though it was about to dislocate, but an actual dislocation or subluxation does not occur. This test variation is called the lateral pivot shift apprehension test. In this video I'm going to talk about the posterolateral drawer test for posterolateral rotatory instability of the elbow. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to Physio Tutors. Posterolateral rotatory instability, abbreviated as PLRI, is the most commonly encountered pattern of elbow instability. PLRI typically occurs as a result of a fall on the outstretched arm, generating an axial load, valgus force, and an external rotation movement about the forearm with respect to the humerus. This causes the radial head and proximal ulna to subluxate posterolaterally away from the humerus in a rotatory fashion, detaching or tearing the lateral collateral ligament complex in stage 1. In a more severe stage 2, the tissue disruption progresses anteriorly and posteriorly around the elbow to the medial side, and in stage 3, the injury involves the medial collateral ligament or even the common flexor pronator origin as well. Although Kamp et al. In the year 2017 described the posterolateral drawer test as the primary examination method and the most reliable and sensitive test for posterolateral rotatory instability, reliability and accuracy studies are lacking. For this reason, we are giving this test a questionable clinical value. To perform the test, have your patient in supine-lying position with the arm overhead and the examiner standing at the head of the table. The hand and wrist of the patient are fixated between the examiner's upper arm and body, leaving the forearm in neutral rotation. For the left elbow, fixate the humerus on its most distal part with your left hand, with the thumb on the posterior surface over the triceps tendon. Grasp the forearm with your right hand, with the index and middle fingers along the anterior aspect of the proximal radius and the thumb on the subcutaneous border of the ulna. The patient needs to be relaxed for this maneuver, which is why a good explanation of the maneuver to the patient is crucial. To help the relaxation, various random pain-free movements can be made first that minimally stress the elbow. When the patient is relaxed, apply a posterolaterally rotatory force to the proximal radius with the fingertips of the right hand while holding the humerus stationary with the other hand. Subluxation is usually maximal between 20 to 40 degrees of flexion, but the test is repeated at various angles from 0 to 90 degrees to determine the location of maximal instability. This test is positive by a visible posterior subluxation of the radial head and dimpling of the skin between the radial head and the capitellum. A clunk sound can be a confirmatory finding which indicates reduction of the radial head after subluxation. If the patient is able to relax adequately, a slight valgus force can be applied during the test to amplify the degree of subluxation. A positive test at a higher flexion angle around 80 to 90 degrees is indicative of marked laxity of the posterolateral capsule and not just the LCL. In this video I'm going to talk about the stand-up test or chair push-up test for posterolateral rotatory instability of the elbow. Get our very own assessment ebook and mobile app. Links are in the video description. Hi and welcome back to Physio Tutors. Posterolateral rotatory instability, abbreviated as PLRI, is the most commonly encountered pattern of elbow instability. PLRI typically occurs as a result of a fall on the outstretched arm, generating an axial load, valgus force, and an external rotation movement about the forearm with respect to the humerus. This causes the radial head and proximal ulna to subluxate posterolaterally away from the humerus in a rotatory fashion, detaching or tearing the lateral collateral ligament complex in stage 1. In a more severe stage 2, the tissue disruption progresses anteriorly and posteriorly around the elbow to the medial side, and in stage 3, the injury involves the medial collateral ligament or even the common flexor pronator origin as well. Regan et al. In the year 2006 did a diagnostic study on the stand-up test, which is also called chair push-up test, and found a sensitivity of 88% with an unknown specificity. For this reason, we give this test a questionable clinical value in practice. The stand-up test makes use of the patient's body weight to create an axial load and valgus torque at the elbow, resulting in posterolateral subluxation of the elbow. In order to perform the test, have your patient seated on a chair with armrests. His elbows are both in 90 degrees of flexion with abducted shoulders and the forearms supinated. Then ask your patient to push himself up from the chair. This test is positive if the patient has apprehension, reports a sense of instability or lateral elbow pain, or if axial dislocation of the radial head takes place.
There is no mulligan technique.
Predisposing factors include past history of tennis elbow, previous lateral elbow surgery, cubitus varus, dysplasia or hypoplasia of the coronoid. Management/treatment include physical therapy, anti-inflammatories for the pain, and surgery if any ligaments were torn during subluxation. Referral includes X-ray and MRI. As you can see in the pictures, the X-ray does not show too much instability, therefore you will need to use an MRI for further diagnosis. Immobilization includes bracing to avoid supination and valgus stress of the elbow and forearm. Prevention includes proper falling techniques so there's no stress on the elbow, and taking care of previous lateral elbow injuries. My PCOT analysis was done on 12 patients. Researchers looked at the different ligaments in the elbow to see if they could prevent posterolateral instability. They compared the radial collateral ligament versus the ulnar collateral ligament. The results included no difference when the radial collateral ligament was removed, but the elbow became very unstable when the ulnar collateral ligament was removed. There was no time frame.